everyone. Today we're going to present our CPC case. Patient is 76 years old, female patient, a diagnosed case of uncontrolled diabetes mellitus type 2 and currently on a short-term insulin therapy for 1 month. Radiologic interpretation: location and number of lesions, posterior mandible, left side, unilocular. Size and shape, approximately 2 cm, pear-shaped. Extent: anterior posterior from tooth number 36 to tooth number 34. Periphery and borders, corticated with well-defined borders. Internal structure, radiolucent.
Differential diagnosis: radicular periapical cyst, most common in third decade of life but occur over wide age range, affect female more than male. On the radiograph, round or pear-shaped unilocular radiolucent lesion in the periapical region may displace adjacent teeth or cause mild root resorption. The distinguishing between a granuloma and a cyst is impossible, although some say that if the lesion more than 2 cm is more likely to be a cyst. Periapical granuloma, most common in second decade of life. On the radiograph, typically there is a radiolucent lesion visible at the tip of the root on a non-vital tooth. This often is associated with root resorption. The radiolucency must correlate with the lateral root surface or the root of the tooth. Histopathology: when examined the tissue of periapical granuloma for disease, hyperemia, edema, and chronic inflammation is observed in the periodontal ligament. Treatment for periapical granuloma is initially treated with a non-surgical procedure.
Differential diagnosis: surgical ciliated cyst developed mostly in the maxilla at the site of previous surgery or trauma, and most common at posterior maxilla, rare occurrence at the mandible, most commonly presenting with a swelling or pain of the cheek and the mucogingival fold. It can be detected by fluid aspiration from the surgical ciliated cyst contained predominantly glycosaminoglycan, hyaluronic acid, and heparin sulfate. The treatment is surgical inculation or curettage or marsupialization if the lesion is extensive and involves the cortical bone. Traumatic bone cyst. The term traumatic bone cyst is determined at a bone cavity of irregular shape which appear like a cyst on a radiograph, and histopathologically there is no element to confirm a diagnosis of a cyst. The pathogenesis are still not clear. There are various possible causes and mechanisms. These are degeneration of bone tumor, disorder in a calcium metabolism, various mild infection, local disorder of the bone growth, venous obstruction. Clinically, it can be detected. The soft tissue are without any change. There is no increased movability of the teeth or change in the color. The teeth are rarely sensitive to the percussion and is rarely sensitive to the pain. The majority of TBC range from lesion of 1 cm in the diameter of those which involve the whole corpus and ramus of the mandible. The growth of some traumatic bone cyst can cause a fracture of the mandible, while others have spontaneous regression. And in the radiograph, they most often appear well circumscribed, isolated, and unilateral radiolucent area which lie under the apex of the root and the tooth on the same side. The treatment is surgical.
The final diagnosis was radicular cyst. Clinical feature: symptomless, slowly enlarging swelling. At first, the enlargement is bony hard, but when increased in size, the covering bone becomes very thin despite subperiosteal bone deposition, and the swelling then exhibits springinescence. The enlargement in the mandible, it is usually buccal and rarely lingual. Sometimes there is a pain and infection. Histology if present: radicular cyst are pathological cavity, partially or completely lined by non-keratinized stratified squamous epithelium in an area of apical periodontitis of a tooth with infected necrotic pulp. In active infection, the epithelial lining of a cyst is thick and irregular and infiltrated with inflammatory cell. In inactive infection, the epithelial lining is thin and regular and has minimal infiltration of an inflammatory cell. The lumen of a cyst may contain cholesterol crystals. Histologically, radicular cysts have been classified as bucket, pay, and a true type of cyst. In bucket cyst, the cyst lumen open into the apical root canal, while the cyst cavity is completely enclosed by epithelial lining in the true cyst. Management: controlled diabetes mellitus, non-surgical root canal retreatment, or root canal retreatment plus apectomy plus cyst removal or extraction.